Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, BBRF's President and CEO, and your host. Today, Dr. Daniel Dickstein will present Brain Behavior Alterations Underlying Self-Injury and Suicide Among Children and Adolescents. BBRF is the world's largest private funder of mental health research grants, supporting transformative discoveries in order to develop improved treatments, cures, and methods of prevention. The high quality of the research we fund is made possible by the BBRF Scientific Council. This group consists of 180 prominent mental health researchers. They review each grant application and select the most promising ideas with the greatest potential to lead to breakthroughs. The Scientific Council guides the foundation to fund creative and impactful basic, translational, and clinical research. Since 1987, the foundation has awarded more than $430 million to fund more than 6,000 research grants around the world and across a broad spectrum of brain illnesses, including addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, obsessive-compulsive disorder, post-traumatic stress, schizophrenia, as well as suicide prevention. Today, I'm delighted to introduce Dr. Daniel Dickstein. Dr. Dickstein is Associate Chief and Director of Research in the Division of Child and Adolescent Psychiatry at McLean Hospital and Professor of Psychiatry at Harvard Medical School. He was a 2015 Independent Investigator, a 2006 Young Investigator, and the 2010 Clairmont Prize winner. Our webinar will begin with Dr. Dickstein's presentation, which will then be followed by Q&A. To submit your questions, please use the Questions tab on the control panel on your screen. Please feel free to submit your questions at any time. Following the presentation, I'll ask as many questions as possible in the time allotted. And now I'm very pleased to introduce Dr. Dickstein. Dan, the floor is yours.
Thank you so much for having me. It's a real honor to be part of the BBRF presentation series. I want to wish everybody a happy May is Mental Health Awareness Month. And again, also want to thank BBRF. As Jeff mentioned, BBRF has been instrumental in my career at several different points. They do amazing work to help advance the science of what we know about mental illness to improve treatment. So it's a real honor to be here to share some of my research. So thank you. I do have grant funding from the federal government and BBRF and other foundations. I don't have any industry support for this or other work. I do run a program called the PD-MIND program, or the Pediatric Mood Imaging and Neurodevelopment Program. Our goal is to identify brain and behavior mechanisms of child psychiatric disorders, ultimately to lead to more accurate, effective diagnosis and treatment using imaging, behavioral tasks, genetics, and detailed multi-informant, multimodal assessment of psychiatric symptoms. And so today we're going to have three learning objectives to talk about the magnitude of the related but distinct problems of youth suicide, as well as non-suicidal self-injury, otherwise known as NSSI, more commonly known as self-cutting, to talk about some data from teens engaged in NSSI versus suicide and controls, to then talk about what can be done to address youth suicide and self-injury now while working to better understand these mechanisms to translate them into better care. So to start with the magnitude of the problem, so this article came out in January 2020. For those of you who don't remember, January 2020 was actually before the pandemic. So if you can try to transport yourself back to a time before there was COVID-19, mass quarantine, etc. Dr. Friedman wrote an article saying, "Why are young Americans killing themselves?" Teenagers and young adults in the United States are being ravaged by a mental health crisis, and we are doing nothing about it. As of 2017, statistics show that an alarming number of them are suffering from depression and dying by suicide. In fact, suicide is now the second leading cause of death among young people, surpassed only by accidents. Dr. Friedman goes on to give some stats and whatever, and then a very interesting comment. So how is it possible that so many of our young people are suffering from depression and killing themselves when we know perfectly well how to treat this illness? If thousands of teens were dying from a new infectious disease or a heart ailment, there would be a public outcry and a national call for action. So I'm not sure we totally know exactly how to treat the illness, but I do think it's interesting. Before the pandemic totally transformed the world, the idea that if suicide is this big of a deal, we should have a public outcry and a national call for action. Unfortunately, I'm not sure we're there. So I want to talk about two prototypical children. These are two prototypical children that I've treated both when I was in a combined pediatrics and psychiatry program. I've treated many of these versions of kids, and I think to me, these are the kids that have guided my interest in research and guide my interest in research and clinical care to the present. So, and these names are just totally made up. So Jack is a 5-year-old who has fatigue, fever, joint pain, a swollen belly, and bruising. These symptoms lead Jack's parents to take Jack to the doctor. The doctor examines Jack. His spleen is big, his liver is big, Jack's pale. Jack's doctor orders a biomarker. Nothing that fancy. A complete blood count, something we've all had to check out many things. This biomarker shows that Jack's white blood cell count is very low, and there are too many blasts, immature white blood cells. So symptoms plus a biomarker have led to an early, very specific diagnosis. It leads to mechanism-targeted treatment, and it's going to lead Jack to have a better prognosis and outcome. So Jack has ALL, the most common form of childhood cancer. And while there's nothing good about cancer, kids do die of cancer. Cancer does ravage families, and it's definitely something that I wouldn't wish on anybody. What's interesting is that this is actually the triumph of research. The survival for ALL is now over 95% 5-year survival. How did we get there? What changed that cancer went from an absolute death sentence in the 80s till now 5-year survival of 95% or more? What happened was people, families, clinicians, funders, organizations all got together and said enough of our kids dying of cancer, much like the newspaper article. There was a war on cancer. Every kid is now part of research if they're getting cancer care. And so that led to better refinement of the mechanisms of cancer, better earlier treatment, better sense of prognosis. So it's totally changed things for the Jack of the world. Another kid, Riley is an 8-year-old who's very moody. Sometimes Riley can be irritable, angry, and destructive. Sometimes Riley can be sad, sullen, and want to die. Sometimes Riley can be hyper, silly, and goofy. At 4, Riley got therapy for anger and not following directions. At 6, because of anxiety, Riley was started on an SSRI and got therapy, but after a few weeks was out of control in terms of behavior and was hospitalized. Do we have a test to figure out what diagnosis or diagnoses Riley has? What treatment would work best? What's the prognosis in 5 years or 10 years? What's the risk for suicide in 1 day, 1 week, 1 month, 1 year? Should Riley go to the ER for an evaluation? Should Riley be hospitalized for psychiatric care? The Rileys of the world have no biomarker to guide their care. And so for me, most of my career is spent trying to figure out how do we get the Rileys of the world, those struggling with mental illness, to have as good a care as the Jacks of the world, the kids with cancer. Some data, and this is not exactly an uplifting slide. This is a CDC slide that shows the 10 leading causes of death by age in the US. In orange in the middle, so suicide is the second leading cause of death, starting at age 10 all the way up to age 34. Cancer is no longer a top 2 or even 3 once you get to teenage years. It's no longer a big cause of death, but suicide is. And unfortunately, rates of suicide in the US for teens from the 70s till now, it depends on your perspective, but one of my first research mentors who was a surgeon used to use a big pen across graphs to show that really for girls, for females, natal females, this is basically a straight line. and for males, by and large, a straight line. So completed suicides more or less have gone up or down, but not exactly changed that much. And it's not just the completed suicide, that's the tip of the iceberg. So the CDC does the Youth Risk Behavioral Surveillance Study. For those of you who aren't familiar, this is a representative study in the US looking at all sorts of behaviors, substance use, mental health stuff, physical exercise in kids. So it's not just suicide focused. These data are published online, and the most recently available data from 2019 showed in the past year among high school students in the US, at least 18% seriously considered ending their life at least once. At least 16% made a suicide plan at least once. At least 9% made a suicide attempt at least once in the past year. And 2.5% sought medical attention for their attempt. So it's the 2.5% that most of us in mental health care, that's where we're mostly working. But if you think about it, almost 1 in 5 kids have seriously thought about killing themselves at least once. Again, this is before the pandemic. If you break down these rates, on the left, those who made suicide plans, on the right, those who made suicide attempts, what you're seeing is a slight female predominance. And in terms of suicide plans, roughly similar rates across race and ethnic groups. But in terms of suicide attempts, far more Black African American youth have made a suicide attempt than whites or Hispanics. Again, these rates are relatively stable, which is unfortunately very concerning. This is data, if you sort of break out some of the time periods from comparing 2000 to 2016, 2000 is dark blue, 2016 is the light green. What you're basically seeing is that suicide rates have gone up at least 30% in about 50% of the US states since 1999. Also concerning from the CDC stats of which this came, more than half of those who died by suicide had no known mental health disorder. So they did not have big red flags that this person might actually end their life, unfortunately. This is a study by Joe Franklin. He did a meta-analysis of 50 years worth of suicide research. He looked at what are people researching to try to understand what's going on in research. The Kentucky Derby was just this past weekend. As a native Kentuckian, I watched. This study by Joe Franklin is like the Kentucky Derby, a horse race where the same 5 horses win, place, show +2 each time period. Just they change in slight order. There's nothing that really breaks in terms of a new horse, unlike the Derby for those who watched it. Those 5 things that you see are demographic factors, things like age and sex, internalizing problems, things like anxiety and depression, externalizing behaviors like substance use or bipolar disorder or anger, social factors like relationship loss with family or romantic relationships, and prior suicide and life-threatening behaviors, which is an important risk factor. But these are all risk factors that on all of our ER risk sheets or outpatient risk sheets, as we're evaluating what does this kid need, this is what we look at. There is data to support these things, and they are all important. It's just there's nothing substantially new breaking into the pack. And if you look at how these factors predict a subsequent suicide, Joe Franklin found that it's little better than chance. So this is another study or an article, this is an article about one of the people who survived the Parkland school shooting, who ultimately in 2019 ended their life, which is incredibly sad. I think this is important because they talk about, so this person survived a huge trauma, big risk factor. They had other risk factors, being a teenager and other things like that. People knew this person was at risk, they're all at risk. Unfortunately, they ended their life. They said that she never asked for help. I show this not to bring up sad things. This is a sad topic, but it's an important topic because even people we know who are at risk, unlike the jacks of the world, we can't just put them in bubble wrap. We can't just isolate them. We can't just keep them in the hospital forever so that they don't end their life. We need to know more about the mechanisms. What really does predict when somebody's going to try to end their life, you know, in 1 hour, in 1 day, in 1 week. The prioritized research agenda for suicide prevention and action plan to save lives came out in 2014. This really inspired some of my research. Most of my early research was in bipolar disorder, and I still do work in that field, and irritability. But as a clinician, seeing patients with self-injury and suicide, reading these reports, I sort of opened a second line of research, again, thanks to support, including that from BBRF. But this agenda talked about sort of 6 ways to try to change things. To identify, why do people become suicidal? How can we better detect and predict risk? What interventions or preventions are effective? What services are most effective for treating suicidal behavior? What non-healthcare centered preventions and interventions work? And what new and existing research infrastructure is needed to reduce suicidal behavior? So there's lots of stuff about suicide, but I was also interested in non-suicidal self-injury. So non-suicidal self-injury is defined as the deliberate destruction of one's own body without an intent to die. It's often done by cutting, but it can also be repetitive erasing, scratching, burning. It's done on arms, thighs, and stomach, areas that might potentially be hidden. For some people, they call this a suicidal gesture, the idea that somebody might be doing this to provoke a reaction. But I don't know if that's a great term, because it's not clear to me that these kids are always doing this to get a rise out of people. Though for many people, seeing the marks of self-cutting does lead to their own reaction. But I don't know if that's always intended by the kids who are doing it. It's not clear that there are sex differences, even though some people say this is only natal females. It seems like there aren't really socioeconomic status or ethno-racial differences. And it's a growing problem. So several studies showing that maybe 25% of adolescents, 25% of those seen in the ER for self-harm, more kids from the 90s to 2000s. And I got interested in this again when I was a resident. I remember reading about this, going to evaluate a child in the ER for possible admission. And I asked, we weren't at that time trained to ask about self-harm and self-injury. It wasn't maybe as well known. And I asked about it, and this young natal female said she did engage in self-injury. And I said, you know, where, how, can you tell me about it? She was in a hospital, Johnny, not much, you know, place to hide things in terms of arms. Most of her arms were exposed, legs to sort of the mid-thigh. And she showed me, she pulled up her hospital gown, the little sliver of sleeve, and showed that she had about 20 different cuts, essentially in that little 1 inch or nothing sleeve area that the family had never seen. That definitely caught my attention and wanted to do more work in the field. By definition, NSSI is not about wanting to die, but it's definitely a risk factor for a suicide attempt. So the treatment of resistant depression in adolescents, Tordia, showed that baseline NSSI predicted future suicide attempts better than baseline history of a suicide attempt itself. Baseline NSSI predicted future suicide attempts among teens despite controlling for past suicide attempts in a study by Cox and a study by Guan and Prinstein, a history of non-suicidal self-injury among high school students increased risk 7-fold. So not 7%, but 7-fold, increasing the risk for suicide attempts in high school students despite controlling for prior depression, suicide attempts, and gender. So it's a problem that we don't know enough about NSSI itself and the interrelationship to suicide. So having talked about the magnitude of the problem, I want to talk about sort of my first foray into this field. And so for me, I guess I was reading all these articles, I was doing bipolar research, was trying to sort of branch out a little bit. And a lot of the articles I read were sort of, they talked about the similar theoretical models for suicide and non-suicidal self-injury among kids. So they talked about, is this an interpersonal stress thing versus an intrapsychic conflict? Is this emotion generation? Is this emotion recognition? Is this about cold cognition? Is this about decision making? Is this about reward? Is this about impulsivity? So cognitive things not necessarily done with an emotional background to them or an emotional focus. And all the articles in the end said, well, it's just about emotion regulation. And there weren't many studies at the time. This is sort of, you know, about 10 years ago, we started this work. that's still underway, which we'll talk about. There were a few studies of pure non-suicidal self-injury kids who had never made an attempt compared to kids who had made an attempt but had never engaged in self-injury. And there are a few studies looking at the mechanisms, both behavioral and imaging, underlying all these theories. So we dove in, and our first studies were all about behavioral tasks because we didn't really know where to look. There were too many different theories to test. We were lucky to have some foundation support to start this work. And so our participants were kids who engaged in non-suicidal self-injury only. They had to cut at least in the past month with at least 5 episodes of it with no prior suicide attempt, or kids who had made a suicide attempt but had never engaged in non-suicidal self-injury, or healthy controls who had no mental health illness themselves or in their first-degree relatives. Their IQ had to be at least 70, they had to be fluent in English, at least in the teenage participant, to do what we were asking. And our first foray was about psychopathology and demographics, as well as behavioral task performance. So this is some of our data that I'm excited to share. So if you look at sort of some basic demographic factors, we were looking for teenagers. They were all sort of middle teenagers. There was a slight female predominance in the NSSI group. Again, we weren't recruiting by gender. That was sort of something just to learn about. In terms of the onset of suicidal ideation, so again, NSSI kids can have thoughts of wanting to die. They just couldn't have acted on those thoughts. They couldn't have done something with the intent to end their life, including self-cutting or whatever self-injury they were doing. So our NSSI kids had earlier onset of suicidal ideation. Also, interestingly, they had earlier onset of their self-injurious behavior. So the kids who cut themselves started cutting themselves and started thinking about wanting to die at an earlier age than the kids who had actually attempted suicide. In terms of why they did it, and a lot of people have sort of a prefabricated notion of why they did it. So we asked the kids. And what was interesting, we found significant differences in that the kids who had attempted suicide had significantly more endorsed to escape something or others by attempting suicide than the kids who were cutting themselves. Whereas the kids who were cutting themselves engaged in self-cutting and self-harm more because of their current emotional state than the kids who had made a suicide attempt. We did look at some tasks, and I won't go through all of them, but one of them was something called a prisoner's dilemma task, which gets at peer acceptance and rejection. And for those of you not familiar with this task, it simulates it's an economics thing. It simulates social situations using reciprocal economic exchange, or in normal human speak, people can win or lose money depending on whether they choose to cooperate or not cooperate with somebody else they're playing. Every round, you see the other player's decision, so you know if the other player you're playing against is playing nice and cooperating with you a lot, or you know if they're not cooperating, if they're hosing you a lot. And it allows us to look at how they play in terms of strategy, but also their self-report of stress. And this is what the screens look like. So if you out there are playing, you would be green, and you could cooperate or not cooperate, and you'd be playing with somebody else who'd be in fuchsia. And what was interesting is that over 95% of our kids believe they were playing with kids in other parts of the hospital or at other hospitals. So thanks to the power of video games, multiplayer games were entirely believable, and nobody really doubted us. But so if you actually cooperate and the other player cooperate, you each get $2. If you don't cooperate and the other person doesn't cooperate, you each get $1. If you decide not to cooperate and the other person does, you get $3 and the other person gets nothing, and vice versa. If you choose to cooperate and they don't cooperate, you get nothing and they get $3. So if you're an economist, the answer is cooperate all the time. No matter what the other person does, keep cooperating. Over time, you will end up doing fine financially. And so that's the option grid. In this case, the middle slide B, our person chooses to cooperate. And on the third panel, both people cooperated, so they did what the economist said, and they both cooperated, so they both earned $2. What was interesting though, while we had thoughts about the play, we thought that in some ways, our kids who had attempted suicide might be more vulnerable to not being cooperated with by the player, there was no difference in actually how people responded to the play, but there was difference in self-reported stress. So kids who engaged in non-suicidal self-injury had almost 3 times the amount of self-reported stress while playing as those kids who attempted suicide, and almost twice the amount of self-reported stress as the healthy controls. So in some ways, this was kind of surprising to us. Another thing we did was in collaboration with Matt Nock, who has done a lot of work with the implicit association task. And Matt Nock is at Harvard, and he collaborated with me before I was at Harvard, and we're still collaborating as I'm at Harvard. But basically, to look at unconscious bias towards things, what Dr. Nock has done is built on the paradigm of an implicit association task to move it into the suicide and self-injury world. And so basically, you classify things in the middle, in this case, either cut skin on the left or the word overdose on the right. You classify the middle thing according to categories at the top. The categories at the top are pairings of either me, not me on different sides, and the behavior and the opposite of the behavior on different sides. So on the left, you see cut skin with me and cutting on one side, and not me, not cutting. So if you've thought about the central picture before, and the word that represents it is paired with me, you will respond faster to classifying this picture on the left of cut skin as me and cutting. If, on the other hand, you've never thought about cutting yourself, you've never engaged in cutting yourself, if you see cut skin and me and cutting, you're going to sort of slow down. You're not going to pick that because that doesn't represent you. And so you classify the stuff in the middle twice, once with cutting and me on the same side, and once with cutting and not me. And you can look at the differential reaction times, and again, you respond faster to things you have a bias towards things you've thought of before. Complicated slide, but don't panic, let's walk through it. This is showing data from Dr. Glenn and Dr. Nock looking at the implicit associations in over 7,000 adults. And what it shows is that these implicit associations robustly map onto self-harm. So in the top left panel A, what you're showing is in this implicit association task, and bias towards something is less negative or more positive. But what you're seeing from self-injury, death, and suicide is that people who engage in non-suicidal self-injury has a stronger implicit bias towards self-injury, death, and suicide than people who've never engaged in non-suicidal self-injury. The top right panel showing the same thing with suicide attempters having a stronger bias towards self-injury, death, and suicide. C, the bottom left panel showing a recency effect, the idea that the more recent you've done the self-harm behavior, the stronger your bias towards that if you've engaged in the behavior before. So people who've engaged in NSSI, if you did NSSI in the past week compared to lifetime, more recently, you have a stronger bias towards towards self-injury, death, and suicide. And the same thing for suicide attempters. So what we found was people who had engaged in non-suicidal self-injury compared to pure attempters who had never engaged in NSSI and healthy controls, on the left had a stronger bias towards escape. Again, that goes with a lot of literature that made sense to us. They have a stronger bias towards cutting. If we didn't find that, we'd be worried. But what was interesting is that those kids who had engaged in non-suicidal self-injury, who had never made a suicide attempt, had a stronger bias to death and suicide-related words than even those who had attempted suicide, which again was a very surprising finding for us. We had actually obviously predicted that people who engaged in attempting would have a stronger bias, but that's not what we found in a sample of about 45 kids in each of the 3 groups. So in summary, so non-suicidal self-injury, NSSI, is a serious problem associated with earlier onset of self-harm behavior in our study. Greater implicit association, not just with cutting, but also with death and suicide on the implicit association task, and greater self-reported stress during interpersonal collaboration and conflict to peer acceptance and rejection. But this led to more questions. So why haven't these NSSI-only kids tried to kill themselves yet? And I say yet in parentheses because it wasn't a longitudinal study. But these kids had every means to try to end their lives. I mean, most houses unfortunately have lots of things. Plus, these kids had all sorts of sharp implements, but they hadn't done it, at least yet in our study. What is the brain mechanism of why people engage in non-suicidal self-injury that might lead to better diagnosis, better prognosis, or figuring out what and when might happen, or targeted treatments? And then what is that transformation that some people, again, 7-fold increase in making a suicide attempt? What's that mechanism? How do you predict that? If you could predict it, then maybe you could avert that. So the third thing we're going to talk about is what can we do now? And then how can better understanding of brain mechanisms be translated? So this is a graph, several graphs that show increased rates of hospitalization for suicide ideation. Rates of ER evaluations or hospitalizations are going up and up and up. You know, we don't even have enough beds. Many surveys, many reports talk about the number of kids filling ERs, waiting for a bed because there aren't enough beds. Lots of states are trying to add capacity for psychiatric care for the first time in a while, thanks to the pandemic and the problems, but they don't have enough staff. So it's an interesting time to be in mental health. A lot of people ask me, you know, Dr. Dickstein, so the pandemic is all bad, right? The pandemic was universally bad for suicide and mental health. And so this study by Dr. Yard shows that's not necessarily true. So at different, you know, this is not just one pandemic. And I know, you know, many of us, you know, as we're in year 3 of this, have a hard time remembering what day of the week, let alone what was going on 6 months ago or 2 years ago. But the pandemic isn't just one experience for kids on the left or adults on the right. As different things go on, quarantine and lockdown, increased rates of infection, vaccine. This pandemic has been different things to different people. As some people say, you know, I've heard some patients in some way say some of the pandemic helped them if they had access to physical space, if they had access to Wi-Fi. For some of my anxious patients, in some ways it was easier because they didn't have to necessarily be with peers. That was a good thing, although reintegration has been hard. So again, I think you can't just say the pandemic has been universally bad. I do think it has led to increased recognition of the importance of mental health for everybody and increased need to address services. Some states have worked on zero suicide plans, and the idea of this, it's a Swiss cheese model. So the idea that Swiss cheese has holes, but ideally, if you lined up a whole bunch of Swiss cheese, it would be hard for someone to get through all the holes because the holes don't usually line up. So the slices of Swiss cheese are different tools to build in between the person and their actual suicide attempt. Those things include screening, assessment, and risk formulation, safety planning, treatment, and then longitudinal care. This is another way of looking at it. Again, talking about what can we do for the individual, what can we do for relationships, what can we do for communities, and what can we do as a society to address risk factors, from mental illness all the way to lack of resources and lack of financial resources, all the way up to interventions as a way to, there's not going to be one magic bullet, just like there wasn't one magic bullet for Jack and cancer. It took a whole systems approach to help the Jacks of the world with cancer. Other things, so I think asking about non-suicidal self-injury is important. It's hard to do, it's not always done. Don't assume somebody has done it or why they're doing it, but just ask, have you ever cut yourself on purpose? Have you ever burnt yourself, scratched yourself, erased yourself on purpose? When? Why? Assessing for suicide is important, but it may be a separate problem. Again, NSSI is a risk factor, but not everybody engaging in NSSI always wants to end their life. And we can't just hospitalize every kid who's engaged in non-suicidal self-injury, just like we can't really hospitalize every kid who's thinking about suicide, because that's a fifth of our high school students at least once in the past year. Also, not assuming it's what this is. I mean, really asking and knowing our patients is important. I think substitution is important. I learned this from my patients. If somebody needs that stimulus while you're trying to work on why they need it, immersing your hand in cold water bath, sort of a cold pressor task, mostly water, some ice. For some people, if they need that pain sensation, can do that without making scars. How do you ask? Well, NIMH developed a screening tool to ask the Ask Suicide screening questions. This is a great, essentially 5-question survey that helps people who don't do this that often ask reasonably about suicide. So in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? Have you ever tried to kill yourself? And if they say yes, are you having those thoughts right now? What's great about the Ask is not only does it provide the questions, but it also provides a guide for, based on what they've said, what do you say to validate and make the person feel comfortable? And also, what do you do with the outcomes? And this may be too small, but the one downside of the Ask is that the disposition, essentially, if they have risk for suicide, often you're leading to a higher level of care, which ends up being in the ER, because we just don't have great ways of predicting for the individual child, what do they need, when is their immediate suicide risk, and can we avoid hospitalization? So that's the one downside of the Ask, but it's a limitation of the field. But not everybody can go to the ER. Also, who do you ask with the Ask? This is a study in pediatrics from 2019 showing what sort of we all know about parents. Parents, even the best parents, don't really know everything of what's going on in a kid's life, including when it comes to suicide. So this is a study of over 5,100 adolescents who they asked the adolescent and they asked the parent, do you think there's anything going on about suicidality? And so there was, it showed that 50% of parents were unaware that their kids thought about killing themselves, and 75% of parents were unaware that their kids had recurring thoughts about wanting to die. So if you just ask the ones you know about, you may miss half or more of the kids who need to be asked. This is a study from lots of folks looking at stuff in the ER. So if you ask everybody in the ER, not just the mental health patients, are you thinking about suicide? And then you have a follow-up, some resources, a post-ER phone call. What was interesting is that this was able to reduce absolute suicide risk by 5% and a relative risk reduction of 20% with a simple ask everybody and then have a brief phone call to make sure they're okay and give them some resources. This is a study from Barbara Stanley and a number of people talking about safety planning. Again, most of you may know about safety planning, but for those of you who don't know about safety planning in this study showed 45% fewer suicidal behaviors in 6 months at follow-up and doubled the rate of keeping at least one outpatient follow-up. So really important outcome from the idea of trying to make a safety plan with patients, having them figure out what are their triggers of self-harm thoughts, what are the things they can think about or do to try to avoid acting on those things. And by having that plan, by having thought about it in advance, they might actually use that plan in the heat of the moment. A lot of times these things are on paper. I want to highlight the My3 app. Again, no ties with this. It's a great app that's been developed. It's free. What's great about the My3 app is, first of all, it puts these tools into the pockets, literally, of teenagers on the thing they carry with them everywhere. Bathroom, shower, everything, their cell phone. So it's not a piece of paper that they're going to recycle, not use, or whatever. It's on their phone. It allows them to put on speed dial 3 of their buddies who they could just press a button and get help right away to talk to them. It has the National Suicide Prevention Lifeline. It has 911, all on insta-dial buttons. The other thing I like about it is that it has the safety plan right there, and you can look at warning signs, coping strategies, distractions, your network, keeping yourself safe, reason to live. You can update these things. Again, that's the idea about a safety plan. It's not just today's safety plan, but it may change tomorrow. What if you are no longer friends with somebody? You don't want a safety plan with them. You might want to put somebody else there. So it can be continuously updated. It's accessible. It's on the device all the kids and even adults carry with them. And it can be sent to therapists so therapists can get a sense of what's going on. So that's stuff you can do now. in my PD Mind program at Mclean, we're following the example of childhood leukemia, where better understanding of biological mechanisms has transformed childhood leukemia from absolutely fatal to a 5-year survival of 95%. We're very interested in improving the brain behavior mechanism understanding of youth suicide, non-suicidal self-injury, and also irritability that could ultimately improve how we diagnose and treat these most important child mental health issues. These mechanisms matter. I'm just going to click through this because they matter because they may lead to better prediction of non-suicidal self-injury and which kids go on to make a suicide attempt. They could lead to mechanism-based treatment for these conditions, including computer-assisted cognitive remediation, so to retrain the brain to use specially designed video games to fix some of the things that we've shown and other people have shown are impaired, like response to peer acceptance and rejection, or like implicit attitudes. If you fix the cognitive skill, would that lead to improved outcomes? It could even lead to mechanism-tested medications or other therapies like neurostimulation. And in my program, we also value partnership with clinicians of all disciplines, nurses, social workers, physicians, psychologists, families, teachers, schools, community organizations, and again, very lucky to have funding from BBRF and other folks. So we've launched a study to try to understand two things. What's the brain mechanism that differentiates kids who cut themselves from healthy controls, with baseline imaging to follow up on the response to peer acceptance and rejection, and baseline imaging of the implicit attitudes about suicide, along with multimodal ways of assessing suicide and self-injury. And then we've added a longitudinal component to follow people for 18 months to figure out which baseline mechanisms predict a subsequent first onset suicide attempt, because that's ideally what we want to prevent. We don't want to, like the 5-horse race, we don't want to wait till somebody's tried but survived a suicide attempt to say, hey, that person's at risk for suicide. We want to stop it before the first attempt, because again, unfortunately, many of these kids may die with the first attempt. This study was started in part with BBRF funds, which I'm very appreciative of, and that led to NIMH R01 funding, which I'm also very appreciative of, so we could add the follow-up. This is some early data. Again, these are early days. We're still working on the data. Moving the study along during COVID is not the easiest thing, but we have, thanks to a wonderful PD Mind team and the wonderful folks at Mclean. But basically, the way this works is we have a chat room task that was developed by NIH resources, both at NIH and Pittsburgh. And so our person, the smiley face, says, who would you rather talk to about movies or other topics? They say 2 age-matched peers, and they get to decide who they want to chat with. So in this case, they've decided to talk about movies with the person on the right. Then this gets switched around. Our person then becomes the subject, and sometimes we have a mean peer who doesn't like our person, and then that'll switch around, and we have a nice person who may like it. So we can look at peer acceptance and rejection again. The peers are foes, not real people, but over 95% of our kids believe they're scanning with other people. What this preliminary result shows is that healthy kids compared to kids engaged in self-injury have the exact opposite pattern of brain activation in key brain areas, including the anterior cingulate cortex, an area that's responsible for handling conflicting stimuli. And so the healthy control kids, when they're being selected, brain activity goes up, but our kids engaged in non-suicidal self-injury have significantly more brain activation when they're being rejected. Again, it's a preliminary result, but this could suggest a brain mechanism that we could target potentially for cognitive remediation to improve this retraining, or to think about how medications might affect anterior cingulate cortex function in a novel way to improve this. This is an example of what would you do about it. So again, Joe Franklin did a study with Matt Nock developing sort of an app to essentially train attention away from self-injury and self-harm and decrease aversion to oneself. He published 3 studies at once, so this is definitely a good read from Dr. Franklin. And basically what he found was that this training did reduce non-suicidal self-injury. It reduced suicide plans, it reduced suicidal behaviors, but it didn't reduce suicidal ideation. Unfortunately, after you stop, the effect goes away. And that's true for all apps. Think about your own app use. Exciting apps, we don't necessarily engage with them for a long time. So this idea of durability, does the treatment work after you stop the app, or engagement, can the app still be interesting after a while, is something that people are looking at. This complicated slide sort of unites my two areas of interest in irritability and suicide. Dr. Ori did a pathway association between childhood irritability and adolescent suicide published in JCAP, essentially showing that different forms of irritability could lead to suicide in different ways. So persistent chronic irritability led to suicidality through depression symptoms, whereas rising irritability led to suicide a different way. And again, we're sort of looking at this in my own lab because we have a study looking at kids who've attempted suicide to try to understand if mechanisms underlying irritability and frustration, how that maps on neurally to these kids who attempted suicide, both initially as well as there's a bit of follow-up to see does it baseline predict subsequent repeat suicide attempt or self-harm. So in summary, non-suicidal self-injury, self-injury without intent to die, is important. It does place kids at a higher risk of making a suicide attempt, and it's not at all clear that all the kids engaged in non-suicidal self-injury need to go immediately to the ER and inpatient care, but we're just not good at predicting which kids engaged in self-harm may make that first attempt, or when will they make it. And it's a growing problem. It's associated with earlier onset of self-harm, greater implicit association with cutting, as well as death and suicide, greater self-reported stress to peer acceptance and rejection. Safety planning is very helpful and important because there will never ever be enough ER beds or inpatient beds to hospitalize all these kids, unfortunately. And we're trying to understand what are the mechanisms underlying non-suicidal self-injury, what's the mechanism underlying that transformation to a first onset suicide attempt, and then repeat attempts. And together, again, following the model of cancer, we can make a powerful difference where providers, families, researchers, funders work together to do mechanism-oriented research for a precision medicine approach to the diagnosis and treatment, prediction, and ultimately prevention of self-harm, of suicide, and other conditions. So with that, again, I really want to thank everybody for tuning in. There are a lot of great researchers who are out there in the field doing this work. We need more people doing this work because together, that's how we're going to get forward. And thank you very much.
Dan, thank you for an excellent, excellent presentation and for the work that you've done and continue to do on such a very important topic. I want to you spoke about the importance of asking, of screening and asking. And I want you to address something that people often have a concern about, which is that by asking about it, it may give somebody the idea. And we know that asking about it actually could save a life. Could you speak a little bit about any risks in asking about suicide?
So I think it's a great question. Again, smarter people than I have done a lot of research on the idea of asking and what it does. But when I think about it, I guess I start with the CDC's youth risk behavior surveillance, showing that essentially 1/5 of the high school kids have thought about wanting to die at least once. So chances are the person who's asking is more afraid than the person who's being asked, because chances are the person who's being asked has actually thought about it. So I think getting over that is important. That's, again, if you don't do this kind of work, if it's not part of your daily thing, I do like the ask. I think the ask is an amazing instrument because it actually helps the person who's asking as much as it does the person who's being asked to feel comfortable, to know what you're supposed to say, to know what you do with that information. I also think it matters the context, right? So, the idea isn't you're just going to ask everybody all the time, every day, every minute. The real key is, in what situations does it make sense to ask? But it is something that, Jeff, you're right. People do talk about, worrying that the act of asking will make somebody do that. And so again, I think odds are that's probably not true.
Good. Thank you. Somebody sent in a question about how a family member can monitor their child or adolescent without being too intrusive, but on the other hand, still monitoring them to make sure that they're safe. Any guidance and suggestions along those lines?
So again, I think that's a great question. I think that's one that both clinicians and parents struggle with. True of lots of things, right? Not just suicide, true of substance use, true of, maybe risky sex behaviors. So I think there's no one perfect way to do it. I do think creating the dialogue is the most important thing. Having a parent try to find a way to talk to the kid and to get on the same page about the need for monitoring. And while the kid may not want that monitoring for any of these behaviors, any of the risky behaviors, I think making sure the kid knows that this is, why this is going on, and in some ways to get the kid's partnership in that, I think is important to take the conflict out of it and to make it more collaborative.
Good, very, very good suggestion. And certainly you want to be on the same team and not feel as if it's a conflict as much as possible.
Yeah, I also think that, a lot of parents, we talk about getting rid of medications because they're at risk. I think that's complicated because every household has these things, but I do think it's worth thinking through, having giant bottles of things that we know are common and lethal, just easily accessible. That may be something that's worth lots of people thinking about. So the 1,000-count bottle of ibuprofen or aspirin that's sitting there, maybe that's not the greatest thing for most people to have on their shelf, to put some distance, some barrier between a commonly available lethal means and an actual impulsive act. Because some people show it's like 30 minutes between the idea of a suicide attempt and somebody doing something. So anything you can do to put space of time could help.
I think that's a very good point and important guidance. I would think of if in a home there's firearms, to make sure that they are securely put away so that there's not easy access to them in a similar way you're describing medication. So absolutely making sure the means are less at hand for the person.
Definitely true.
I want to ask you about the use of potential use of the rapid acting antidepressants, which have in studies shown a decrease in suicide risk in people, again, in a rapid fashion. And I'd like to know where you see this going in terms of potentially helping with the issue of suicide prevention.
So I think it's a great topic. It's not something that I personally have gotten into in terms of research yet. I think I'm most familiar with, obviously some of the work in adults using, I think you're talking about like ketamine and things like that. And then
yes,
Katie Cullen is doing work on this, which is very important, which is impressive as well. But I do think this is an interesting and emerging time when, everything old is new again, when rediscovery of potential role of these medications and how they might help our patients in a new way is pretty exciting. I think my only word of caution is, I think like lots of things, the commercial world's pace of putting these things out there far outstrips the ability to do reasonable research on them. So I think that that's been true in a lot of parts of the country. I think that people have started making these medications available in populations and to people where we really don't know the answer. And I think that's a challenge. That's like an example of where cancer care really did it well, right? So if every place around the country, even if they're part of a private clinic, to administer ketamine had to be part of a database and share that data, they're really doing experiments every day in thousands or more of people. If somehow that was being captured, that would geometrically move the field forward so that the kids and adults struggling with mental illness would be able to have the same degree and quality of care of the people with cancer. And I wish there was a way to do that. I wish that the writer who talked about a national, war or campaign about this, I wish there was a way to do that.
I agree. Very, very good point. If it was some other illness or condition, it would be on the front page of the paper, on an ongoing basis with congressional hearings to take action.
Yeah, and I think it's on the papers, right? I think that's the hard thing is, I don't know about for you, Jeff, but for me, when I start my morning and I, do chores, whatever, and then I look at sort of different kinds of news, it's pretty common on most days, either locally or nationally, somebody has unfortunately ended their life. But yet we don't get to that tipping point of a whole national effort of data collection. And I don't know how we get there.
Yeah, no, I agree with you. One thing that hopefully will be helpful is the development of 988 crisis phone number. Instead of dialing an 800 number, the 988 crisis. Could you say a little bit about that and the impact that you think it may have?
Yeah, I think it's great. I mean, again, so I guess that does represent in some ways a national effort that's been successful to put a single number out there so that people can get help. I don't know what you think from talking to other experts or on your own, you think how that'll make an impact, but I think the idea of it is great. And maybe that's the stepping stone, that if we can get a number out there, then maybe that can lead to sort of more nationally collaborative efforts. What do you think?
Yeah, no, I agree with what you're saying. I think the number can make it easier if you don't have a phone number on an app that you may have to dial a crisis hotline. You could just dial 988. It brings attention to it. And the most important part is each locality will be responsible for what that 988 response will be. So if locations around the country put in place a strong positive response so that when people call that, they get the help they need, whether it be due to suicidal risk or due to agitation as a result of a psychiatric condition. If there's a good response, I think that'll make a big difference moving forward.
I definitely agree with that. I think it's great. Again, the national campaign with local response seems like a great way to do it.
Yeah. I'm going to ask one last question. Where do you see your work and the field going with regard to suicide prevention and non-suicidal self-injury prevention in the next 5 years, next 10 years? What do you see coming down the pike that we could look forward to?
So I think it's a great question. What we're trying to do in my own PD Mind lab is, we have 3-4 studies going on right now that are increasingly interrelated, using both cross-sectional imaging with longitudinal follow-up to understand the mechanisms of kids who engage in non-suicidal self-injury who've never made a suicide attempt, because that in its own outcome is an important thing to understand for targeted treatment. To then follow those kids, some of whom unfortunately will make a suicide attempt, some of whom won't, to understand from a mechanism perspective what predicts that first suicide attempt versus not, that could lead to, again, mechanism-based prediction or prevention. To also study the kids who have made an attempt on some things related to irritability and anger, to understand those mechanisms, again, for potentially more targeted treatment or better diagnostics. And then the other study we're working on initially is purely about irritability and anger from a transdiagnostic perspective, because as you know, irritability is a diagnostic symptom or associated feature of over 12 different disorders. It's the #1 reason kids come to the ER. Childhood irritability is associated with adult suicidality and other poor outcomes, yet we don't have a mechanism-based way to diagnose and treat those things. So it's really all about the mechanisms, understanding them, following the model of cancer care, where mechanisms can be transformed into accurate diagnosis, treatment, and prediction. That's really what my research is all about. And we're lucky to have great collaborators, and we always welcome more collaborators. And again, we are truly, truly grateful to have BBRF, who's been such a big part of my career, helping me acquire funding that did lead to NIH funding to do these larger studies. So thank you so much for what you're all doing.
Well, thank you for what you're doing, and in a large part, what we do at BBRF to get the funding from generous donors is to support you and others doing such extraordinary work. So thank you, Dan, for all that you're doing and for an outstanding presentation. For the people listening today, if you'd like to make a donation, I want to remind people that 100% of every dollar donated for research is invested in our research grants. We're able to do this because our operating expenses are covered by separate foundation grants. This means that when you donate $1 for research, that dollar goes directly to the scientists. To make a gift, please visit our website, bbrfoundation.org, or call us at 800-829-8289. This webinar has been recorded. If you missed any portion or would like to share it with other people, please visit the events and webinar page on our website. And I want to invite you to join us again next month on June 14th at 2 p.m. Eastern Time, when Dr. Galen Messig, senior scientist in vivo pharmacology at Cerevel Therapeutics, will present, does early life inflammation contribute to the risk for developing psychiatric conditions? Thank you, and remember, together we can dramatically improve the lives of those living with mental illness and enable more people to live full, happy, and productive lives. Once again, thank you. Take care.